Okay, I'm going to go ahead and introduce Mishka. And yes, thank you for joining us today, Dr. Terplan. We're so excited to have you. Dr. Terplan, Dr. Mishka Terplan, is a board certified obstetrician and gynecologist, and he's also board certified in addiction medicine, which is pretty remarkable. And because of this dual certification and also his commitment to the field, he has really been an extraordinary advocate for research, public health, and advocacy as it relates to reproductive and behavioral health. He's the medical director at Friends Research Institute and also adjunct faculty at the University of California, San Francisco, where he is a substance use warm line clinician for the National Clinician Consultation Center. He's very active with grants and also emphasizes health inequities and discrimination and access to treatment in his work. He has been instrumental in many of the guidance documents that we use today to provide treatment, medication treatment to pregnant and parenting people with opioid use disorder, and has been part of expert panels at the CDC, SAMHSA, and NIH, and with the FDA. So his expertise is really phenomenal. We're really excited to have you here today, Mishka. And I also will mention that earlier today when I was talking about how excited I am for this webinar, that I also am just grateful that Mishka not only has provided so much excellent service in the field, but he's also really willing to be a mentor towards people like myself who are seeking to improve the way that we treat pregnant and parenting people who have substance use disorders. And so I'll turn it over to you, Mishka, and thank you again for your time. And we will save questions for the end, but feel free to drop those questions that you have either in the Q&A or the chat, and there'll also be time later where we can, folks can be able to be unmuted and ask questions directly.
Great. Well, thank you. And thank you so much for inviting me. I'm delighted to be here. I am going to just restrict that screen. Yeah, so thank you. My name is Mishka Terplan. I'm a physician. I'm both trained in both OBGYN and addiction medicine. I'm going to talk today really to talk about drugs and in utero exposure and consequential like neurobehavioral development through the lens of both sort of human rights and science. And in specifically, I want to highlight a gap between human rights and principles and social justice in practice. And through that, I want to critically examine the literature on in utero substance exposure and subsequent development. I want to review assumptions that we have that are grounded in our experiences in our social historical moment about family separation policies and consider alternatives. And really, the big picture is to inspire us to move from what I will call old questions to new questions, to pivot from a drug focus to really a development focus. First, notes about language. I'm going to use person-centered terminology throughout. For example, people who use drugs, people in recovery, people with addiction. We're going to use terminology that's also evidence-based. Substance use disorder or addiction. Language is going to be gender inclusive. And this is because not everyone with the capacity for pregnancy identifies as a woman, and not every woman has the capacity for pregnancy. And finally, we're going to talk, a little bit, instead of using the phraseology of social determinants of health, I think it's helpful to shift to a more social needs informed or needs targeted language. So this is, the photo of Eleanor Roosevelt holding the Universal Declaration of Human Rights, which was ratified in 1948, on the ashes, really from the ashes of the Second World War. And this is a fundamental document that organizes, the latter half of the 20th century into the 21st century in terms of, both programming and response, governmental responsibility, civil society, and etc. But it took a while for reproductive health to be even articulated through this lens of human rights. Today, the WHO defines reproductive rights to include the rights of all individuals and couples to information, education, the means to decide the number and the timing of one's birth, and the means to attain the highest standard of sexual and reproductive health, free from coercion, violence, and discrimination. But it's, in the simplest form, it's really the right to determine whether and when to have children. But this right to self-determination remains controversial. Having a right and being able to freely exercise it are two different things. The right to self-determination is actually meaningless if people lack access to that right. The universal right to be able to control your reproduction is meaningless if you lack access to contraception and abortion. And this is seen or discussed in this document here, which is from the Human Development Report in 2000s. And they say, and this is the quote, "Human rights are moral claims on individual and collective agents and on the design of social arrangements. Human rights are fulfilled when the persons involved enjoy secure access to the freedom or resource covered by that right." So there's a tension between the promise of human rights and the reality of inequality. In other words, the absence of social justice. So in many ways, the claim to human rights is a moral justification for social change. It's, because rights are meaningless if self-determination and access to those rights do not exist. And this tension really between human rights and social justice really is, in a sense, receives harmony through the reproductive justice lens. And this is a movement led, emerging from the work of Black feminists such as Loretta Ross, pictured here. And the values of reproductive justice are these three: the right not to have a child, the right to have a child, and the third part, which really speaks to the social justice and community part, the right to parent children in safe and healthy environments. So as we talk today about the scientific literature on substance exposure and developmental outcomes, among other things, I want to keep this idea of justice, the moral claim of reproductive health as a human right, and that claim includes the right to parent in safe and healthy environments. I want to keep those close as we interrogate the literature. So I first want to recognize that there are these false dichotomies in the space. And there's, an example of a false dichotomy from a human rights lens is the right of the fetus versus, the right of the parent or the pregnant person. And there's multiple of these sorts of false dichotomies in the drug literature and its interpretation. Thinking about, the exposure first, the in utero substance exposure. The fetus actually has no idea if the drug to which it's exposed is prescribed, is being used as directed, is being misused, is a legal substance or illegal substance, is a natural opioid or a synthetic opioid. Those distinctions are meaningless from the perspective of the fetus. Yet, when we think about sort of harms we attribute social and legal classification to biological and public health outcomes. For example, we assume, that prescribed medications are safer than legal substances, and that illegal substances are more harmful than legal ones. But that isn't accurate. These are social and legal distinctions that aren't categorically biological or public healthy. From the perspective of teratogens, substances that can cause birth defects, almost all of the described teratogens are prescribed. A few are legal, in particular alcohol and tobacco or nicotine to some extent, but none of the illegal substances are really teratogens. In terms of opioids, we talk a lot about opioid exposure, and this is the literature I'm going to interrogate is predominantly opioid focused. But there's a tension between opioid exposure and neonatal abstinence syndrome or neonatal opioid withdrawal syndrome, which is a condition that happens to some infants who are exposed in utero to opioids. They undergo withdrawal after birth. And one problem in the literature is that we treat this exposure as binary. Whereas in actuality, even infants who develop NAS, it's more of a spectrum condition. A second issue is that people can develop neonatal abstinence syndrome from quite different populations. People who are receiving opioids during pregnancy who do not have an opioid use disorder, let's say for a chronic pain condition, those infants can develop neonatal abstinence syndrome. Amongst people with opioid use disorder who are receiving medications, either methadone or buprenorphine, those infants can develop neonatal abstinence syndrome. People with untreated opioid use disorder, their infants can develop neonatal abstinence syndrome. And there's even iatrogenic neonatal abstinence syndrome, which occurs more amongst preterm infants, but these are infants who received opioids, usually following surgery, who develop withdrawal during, the first weeks to months of life. And these different populations all have, different baseline starts and trajectories that influence development. So analytically, when all we look at is neonatal abstinence syndrome as the exposure, we're missing all of the nuance and difference from these particular populations. To take a step back and think about what is neonatal abstinence syndrome, it's withdrawal at birth, and it's due in part to opioid exposure, but and those of you who took epidemiology in college or graduate school are probably familiar with the causal pi hypothesis of Rothman. This describes causality. In that language, opioids are a necessary but insufficient cause of neonatal abstinence syndrome. Because we know infants who develop withdrawal, it's also due to other in utero environmental exposures, medications, other drugs. The postpartum care environment strongly influenced the severity and duration of withdrawal, and as well as sort of epigenetics, in particular, the methylation of the mu opioid receptor, something that we cannot control. This cartoon really illustrates the gaps in knowledge when we try to say there's an association between a birth exposure and something later on in life. In this case, it says performance in school, because I'm going to drill down on that. And there's two big gaps. The first gap is everything leading up to birth. As mentioned, we measure exposure usually as binary, but ideally we would want to know, the totality of the exposure over the gestational period, the route of administration, the quantity of the exposure, the timing, and et cetera. And we don't have that information, rarely have it. The brain keeps developing, right? There's nothing unique at birth about cognitive, changes. It's really not until the early to mid 20s that there's a fundamental shift in the brain. And exposure, which can happen in utero, can also continue through the early years through second and third hand exposure for inhaled substances, and later on through direct exposure when adolescents or young adults take drugs. And in this gap between exposure and birth, there's these, phenomenally important domains: parenting, parent health, early childhood development, which we'll talk about, environmental toxins, presence or absence of the safety net, resilience, nutrition, and violence. And as we move further along in social development, the amount of literature we have falls off. So we know much more about birth outcomes than we do early childhood, certainly than we do adolescent or adult outcomes. It's impossible to talk about drugs and pregnancy and outcomes without mentioning and grounding this in the so-called crack baby era. Really, this has been described as where the war on drugs collided with the war on abortion. There's, like, as you see from these headlines here, sort of narratives that are racist and dehumanizing. You should know that the early literature that found, phenomenally negative outcomes amongst crack cocaine exposed infants, those outcomes were not substantiated with subsequent and better done literature. That the literature overall was primarily carried out in samples of urban, Black, poor people who lived in neighborhoods defined by redlining, oftentimes with poor air quality and other environmental contaminants, and in environments that were also ridden with lead paint and pipes. Most of the people who are in the crack cocaine literature had lower than average levels of education, higher than average incidence of depression, inadequate prenatal care, and exposure to violence. So even if you have the proper comparison group to look at crack and exposure and outcomes, developmental outcomes, there are social and psychological factors and structural factors that will be confounded with drug use and child outcomes. And I'll note that to date, we know nothing about cocaine use by women of higher socioeconomic status during pregnancy and their childhood outcomes. An example of the problematic literature was this. I don't have the PDF. This was an article from 2002 that examined this sort of confirmation bias that showed how the social context in which we all inhabit influences how we interpret scientific findings. And they looked at 163 4-year-olds, some of whom had, some of whom weren't exposed to prenatal cocaine and had developmental testing. And they asked people, who do you think was cocaine exposed? And most of the people who said those that performed poorly were cocaine exposed. And so and although there actually was no difference in developmental test results based upon cocaine exposure, it was this assumption that those who exposed poorly were cocaine exposed. So in other words, they were labeled as cocaine exposed. So when we talk about, this topical area, we talk about like stigma. And a label is a stigma, but stigma is really a euphemism. Stigma relates to a mark of otherness that people have for deviation from the norm. I prefer, the terms discrimination and prejudice, because this reflects how we treat other people. And people who are pregnant, who use drugs, who have a use disorder, experience multiple and layered discriminations for using drugs, for reproducing, for being Black, Indigenous, incarcerated, immigrant, non-native English speaking, mental illness, etc. They're intersectional oppressions that emerge in pregnancy and substance use. And it's not just the pregnant person who's discriminated against, but it's the child as well. As seen in that prior article, like the harm is assumed, and then observations of behavior are attributed to that harm. So this is a summary of, mostly systematic review data looking at opioid exposure and social development. And you'll see that as kids get older, there's a drop off in sort of the volume of the literature. You can see there's a mixture of, some are looking at medications for opioid use disorder, others are looking at prenatal opioid exposure. There's ones that we look at that also look at neonatal abstinence syndrome. So 3 sort of different exposures, multiple different types of outcomes, and overall, the quality assessments when they were done by these systematic reviews, found no studies of high quality. Most were middling to poor. There's great degree of heterogeneity, some of which can be explained through subgroup analysis, in particular for looking at, nicotine and other substance exposure. But overall, the data are equivocal and do not support significant measurable, differences in social development due to prenatal opioid exposure. So I had on that cartoon in the beginning something about education, and that's because I wanted to drill down on this article. Not because it's bad, but because it was talked about a lot. And this was a study in Australia where they linked diagnosis of neonatal abstinence syndrome with high school test performance. And they found that there were lower test scores amongst individuals who had been diagnosed with NAS at birth, and that as the kids progressed in school, the difference increased. So that by the time that they were in mid-high school, they were scoring at 1 or 2 grade levels below people who did not have neonatal abstinence syndrome. To take a step back, there were some things that were sort of missing. Alcohol and nicotine were not measured, or were not available in the data. And they matched on the individual level. And this created differences between the exposed and unexposed group. The cases were younger, they had more children. 15% of the cases, i.e. NAS, were indigenous versus only 4% in the matched. 14% of those with NAS had no prenatal care, versus 5% in the general population. In other words, the outcomes reported may be due to unmeasured confounding of alcohol or nicotine, but also from how the matching happened. And there was this sort of disconnect between matching at the case level as opposed to at the group level. So one suggestion, which I'll mention in a touch, is that really we should think about propensity score matching for large samples, as this can probably better balance covariates and actually achieve more of a balanced sample. Another statistical issue was, the use of significant tests, in particular type 1 error rates set at 0.05, which is pretty standard. This allows for the detection of small effects, but in large sample studies, these small effects may well be trivial. For example, in the column, the grade 3 column here, which had the greatest population, there were 1,600 cases with NAS, 3,200 were in the control, and the overall population was 447,000. So a 0.05 alpha rate would allow for a detection, a population effect of 0.01%, a very small number. And you can sort of back calculate it, which these authors did in this study here on the left, from the F statistic. So if you look at the largest F statistic in this table, which was looking at differences in grade 7 writing skills, and you back calculate, which I've blown it up here for you, you kind of back calculate from that, you can see that neonatal abstinence syndrome only explained 3% of the reported difference in writing score, and 97% are explained, from other factors. So even though you have a significant p-value, it's an artifact of the statistical lens through which you're looking at these data. So when we think about this, it's important that we use clearly defined exposure groups sort of to decrease the heterogeneity. Is it NAS? Is it prenatal opioid exposure? These, et cetera. These are important a priori decisions. We also need to think about an appropriate comparison group, ideally one that relates to the outcome of interest and can illuminate something on the potential causal pathway. As mentioned, we really should not use case level matching, but think about the use of propensity scoring to actually make the two groups more similar. And instead of starting with standard type 1 error rates, we should think about specifying minimum effect sizes from clinical or population health knowledge beforehand. So when we look at the relationship between in utero substance exposure and subsequent development, the causal pathways are incredibly complex. And this is a recent study that models it. And not even, I think you can look at this and think that there are important variables that are missing from this. But the thing to note is not only the complexity, but you see causal loops, as well as DAGs that kind of go back and forth. And we don't really have, or at least I'm not aware of, standard statistical software and that can analyze things like causal loops embedded within a larger causal loop and directionality going in both ways. But just because it's complicated doesn't mean that we can't do something. And I would argue that we need to, acknowledge, the complexity of potential causal pathways between exposure and outcome. That ideally our statistical methods should reflect, the thoughtfulness and complexity of the pathways that we're trying to investigate, but that our work should really focus on those places where interventions are practical, where they're kind, and where results are likely going to be meaningful. We need to be aware of the single cause fallacy. And that's this idea, like when we leap from a measurement of exposure at birth to a measurement of performance in school, and we attribute what we see in school performance exclusively on the birth exposure, we leap over this giant gap and we commit, the single cause fallacy. And second, when we think about how to interrogate, what I've been trying to do, sort of the published literature from this, same perspective of, analytic methods and plausible causal theory, think about the multiple places along the pathway where interventions are, inexpensive, humane, kind, feasible, doable, and there's multiple places along the way where interventions and analysis which center on human rights and social justice that can really help set young people and children up for success. And specifically, I would say it would be attention to early childhood development. And this was the National Academy's report from 2000, following the decade of the brain, comes out at the same time as the CDC Kaiser ACEs study, though this is framed as, sort of a strength-based approach, whereas the ACEs is really not. And they looked at summarized the literature to date on early childhood development and came up with some concrete recommendations. They recognized inequality, that young children are oftentimes the poorest members of society and are more likely to be poor at this time in 2000 than they were in 1970. And I will say in 2022, they're even more likely to live in poverty than they did around the turn of this century. And they, started with these statements or these, recommendations that all children are born wired for feelings and ready to learn, that society is changing and the needs of young children are not being addressed, and that interactions among early childhood science policy and practice are problematic and demand drastic rethinking. And I would say today, 20 years later, these statements still hold true. And we have not, in my experience, adequately integrated, the science of early childhood development into the research on drug exposure and outcomes. And it's unfortunate. The data are there. In general, like, we overstate the importance of the in utero exposure and we minimize the role of the caregiving environment. And the best example of this is really the work of Halam Hurt, who's pictured here, who was one of the first people to get an NIH grant to look at cocaine exposure and outcomes. In particular, her hypothesis was that kids who were exposed in utero to cocaine would have lower IQ at 2 years of age. And when it came to be 2 years of age, when she did the assessments, there was actually no difference in IQ by cocaine exposure. And all of her study participants, almost all were Black, all lived in extreme poverty in, a red line segregated part of Western Philadelphia. And instead of stopping there, part of her brilliance was to dig deeper, because she noted that there was a range of IQ in the study participants, some high, some low, not associated with cocaine. And she started doing sort of home visits and tried to operationalize the caregiving environment. And she found, this is the table here on the right, those aspects that were associated with higher IQ, such as learning stimulation, language, variety and experience. And the one thing that was in some ways least associated with IQ was the physical environment, which I'll say is the one thing that child welfare investigates when it does a home visit. So we know what kids need from this simplistic table to succeed, but that is not the structure in which we interrogate and surveil families. Despite this, I feel like there's a disconnect between, prenatal care providers and knowledge and experience of early childhood development. Although there's some clinics that do attempt to provide dyadic or intergenerational care, there's a real mismatch in terms of how we care for people in the hospital and how we can provide continuing care, in particular through the postpartum period. Because pregnancy is just part of the life course. And we know, I'll touch on this, that the postpartum period, which is the year after delivery, is a critical year for the parent. It's a time of increased vulnerabilities. We see increasing rates of overdose and overdose death, rates that are higher the year after birth than they are the year prior to birth. And some of that is due to treatment attrition, through the postpartum period, which reflects an absence of an adequate workforce to care for people postpartum, as well as reflects sort of an absence of health insurance coverage. But I'll note there's been a lot of movement to not just Medicaid expansion, but also Medicaid expansion for pregnancy through the postpartum period. And that's good, or good-ish, I would say. But health insurance isn't health care. And what happens in every single state but Illinois is that the denominator of need is recalibrated after a birth. And so not everybody who had coverage during pregnancy can continue it, even in this new era of expansion. I don't know why that happened. I also want to touch on the policy environment and the fact that pregnant people, the intersection between drug policy and reproductive health policy is of particular importance, especially in the postpartum period. On the left, these are a graphic from RAND that shows the proliferation of punitive policies at each state level related to pregnancy. And you should know that punitive policies are not associated with any measurable benefit at the population health level. In fact, punitive policies are associated with an increased odds of NAS, of low birth weights, of preterm delivery, and a decreased odds of any prenatal care. And by punitive policies, I mean mandatory reporting, coerced treatment, and the sort of the collapse of using drugs in pregnancy statutorily with child abuse within state statutes. And this is interesting in that, in general, drug policy is becoming less punitive. But drug policy in pregnancy is becoming more punitive. So why? It's not drug policy that drives this increasing proliferation. It's actually restrictive reproductive health policies at the state level are making drug policies around pregnancy more restrictive too. In other words, this, what I said earlier about how the crack baby was where the war on drugs collided with the war on abortion, that intersection persists in policies today. I want to think about, this tension between parenting as a human right, which I initiated this talk with, versus family separation. And this is a quote from the Movement for Family Power's Ground Zero report. The child welfare and foster system holds perhaps the greatest power a state can exercise over its people. The power to forcibly take children away from parents and permanently sever parent-child relationships. So there's a tension between parenting as a human right and the reality of family separation. We're living in an era of really an epidemic of foster placement, driven in part by the opioid crisis, but predominantly driven by provider practices. There has been no change in the past 15 years on the proportion of children reported into child welfare from schools, family, police, and etc. But there's been an over 4% increase in reporting coming from health professionals. And there are marked racial inequities, as illustrated in the graph on the right, in those reportings, with a increase of both American Indian and Black infants reporting rates far greater than white and Latinx infants. And this rests, somewhere, this statutorily driven, assumption is a form of misinformation somewhere. This idea that using drugs in pregnancy is associated statutorily with subsequent maltreatment is an example of a logical tautology. Something that is true or false by definition. In other words, this, which is encoded in over half of state statutes in the US, is not a scientific statement. It's something that is formally undecidable. And these policies create, sort of a climate of mistrust. And trust, is an attitude that we have towards people whom we hope will be trustworthy. And in some ways, when we trust somebody, we have to, accept a certain degree of vulnerability or risk. This is why people say trust is hard to achieve, but easy to lose. But in the context of addiction medicine, and in particular, I would say pregnancy and drug use, it's actually an environment of mutual mistrust. But the mistrust of the provider is different in important ways from the mistrust of the patient. The patient mistrusts and is justified due to historical trauma, as well as the current experience of discrimination. Whereas provider mistrust is actually emerges from discrimination and prejudice. And when we act on our mistrust, we commit what Fricker called, epistemic injustice. We silence the other person. We say what they're telling us is invalid. But the consequence of misplaced trust, that means I trust you, but then I shouldn't have trusted you. You violate my trust. For the provider, the consequences of misplaced trust are actually minor. But for a patient, the consequences of misplaced trust are severe. And this is because of the marked, sort of power differential between providers and patients. Therefore, the responsibility for overcoming mistrust really rests with us and not with the patients. So I want to sort of transition in the end to what we can do. And really, we address in part mistrust and by giving credibility to people who use drugs, people with addiction, people in recovery. We treat people as their own experts. We engage the community and we elevate and support people with lived experience. And this means, again, through the reproductive justice lens, centering on the most marginal. And this is illustrated here. This is from Movement for Family Power, how to reimagine support so that it centers on the pregnant person, on her family, and on the community. We can also think concretely about how we can build trust through clinical discussion. And these are some, examples of questions that one could ask that open the space, for trust. What is the most important thing to you about treatment or recovery? Do you have any fears or concerns? What do you need to feel safe? What are you looking for in a provider? How do you think your care is going? These are all examples of questions that center, on the person. Is it's, Lao Tzu, he who does not trust enough will not be trusted. And more importantly, from the perspective of the patient, what I know you care, I will care about what you know. So it's in this context that I want to sort of reconsider our clinical questions we ask and the policy sort of approaches that we take. I would call things like, what are the proportion of pregnant people who drink alcohol or use drugs, or the proportion of children identified? These are old questions. Even what are the consequences of negative exposure? Not that these are not important, but they're not as important as future forward questions. What do families need to thrive? To what extent do the policies we act not just improve health, but yield equitable health, safety, and well-being outcomes for the birthing parent, fetus, neonate, and child? So in conclusion, I think we need to serve and not save, support and not surveil. And I share with you here, this is a photograph of my mother who's pregnant with me in the first to second trimester. And she's drinking a glass of wine, she's smoking a cigarette. And I share this because one, most people use drugs, to which some people develop addiction. The corollary of that is that most of us were substance exposed. 2, she stopped smoking in pregnancy, never smoked again. And she stopped drinking in this pregnancy, and she drinks periodically, but does not and did not develop, like a use disorder. So exposure is common and it's part of who we actually are. And child development is a complex system, genetic, biologic, environmental, and social variables. Hence, attributing causality to single agents is difficult. Opioids are a necessary but insufficient cause of neonatal abstinence syndrome. Opioids are actually neither a necessary nor a sufficient cause of adverse developmental outcomes, including educational outcomes. And to really flip the script from drug to development, children thrive best when parents are healthy and supported, their families are stable, and their communities are equitable and devoid of violence. So we should focus on high impact, low resource interventions to support equity in early childhood development, regardless of drug exposure. So with that, I'm going to stop. Thank you very much. I'm going to stop sharing the screen, and I look forward to questions and discussion.
Thank you so much, Dr. Terplan. It was great to hear your perspective. And I know that hearing your perspective also leaves me really energized for future work. Are there any questions from others before I start asking? Feel free to either raise your hand or drop questions in the Q&A or the chat, however's easy for you. Oh, okay. Megan Lipset says, can you say more about how the association between substance use and subsequent maltreatment being falsifiable? I want to be able to understand this better.
Yeah. So two things. So I was talking specifically about sort of the statutory association, which says if you use drugs in pregnancy, that equals child abuse. And that's a different question than is using drugs in pregnancy associated with subsequent maltreatment or neglect. So statutorily, it's hard, you can't argue against a logical tautology. You either accept it or can't accept it. It's not a scientific conversation. So that's a legal problem, that's an advocacy problem, and data and science can be helpful in informing that, but in and of itself, it's a universe unto itself, logically. In terms of the scientific data, which I didn't really touch on, there's no end of statements that using drugs in pregnancy is associated with subsequent maltreatment and neglect. I'm working on a systematic review on this topic. There is one that's already been published. So I'll say what their conclusions were. They began with the assumption that that was a real association. We begin with the assumption that it might not be a real association. But what they found was that there's no question that using drugs in pregnancy is associated with child welfare reports. And that's because of that statutory, among other things, that's because of policy. But they said there was limited data to support that it was associated with actual substantiated, abuse or neglect cases, and that the available literature that described that was of poor quality. We're not finished with our review, so I can't say what our conclusions are going to be. And we had a slightly different frame for looking than what they did. But I feel like that likely our conclusions will be similar. So that the strength of the data, the evidence does not strongly, if at all, support that using drugs in pregnancy is associated with subsequent maltreatment. I also want to just problematize how we talk about child, or the categories of within child welfare. There's really two. There's abuse and there's neglect. And abuse is a crime or an event of commission, and neglect is a crime of omission. And those are markedly different things. And certainly there are prejudice and discrimination have played into allegations of abuse. The classic example being the practice of cupping, and which can cause bruising on a newborn that was misinterpreted by emergency department physicians as signs of physical abuse. But neglect, because it's a space of omission, not commission, is where prejudice and there's much more prejudice and discrimination in the assessment of neglect. So even I'm pretty sure I'm not sure we're going to be able to separate out abuse from neglect within the published literature on this, but ideally, one should be able to. and I'll say at least, so there's activity at state levels in terms of policy on this. For example, in California, there's a bill, it's been rewritten, so I don't have a full, a complete sense of what it is, but the idea was to better define neglect, to not have it be as open-ended a bucket for, pathologizing poverty and, the othering of people who are, deemed to be sort of unworthy of parenting.
Megan says, thank you, and looking forward to reading the review. And do you have a key reference you would recommend in the meantime?
Yeah, I could send the other systematic review. I don't have it off the top of my head, but it's close by. But I would say that would be a decent place to start. And then there's a lot of there's an emerging critical literature on child welfare as well. Like anything, like Dorothy Roberts wrote a Washington Post editorial the other day, which is really, as awesome as like everything that she has done is.
Are there additional questions? I think that my interest is also sort of in this the postpartum period and thinking about like how that also plays out and understanding more about, I think, we know that relapse is more likely, right, when people experience the violence of child removal, and how those sort of, in your role as a provider and also in your role as a researcher, how have you sort of seen those interactions play out over time, like shortly after birth, especially, for people who don't have a removal at birth, like what does that sort of dance with the different systems look like?
Yeah, I'll say anecdotally, I agree with you that removals are a form of destabilizing like people who've been rendered vulnerable, and hence increases the likelihood of return to use, overdose, and overdose death. The data to support that aren't quite as robust as I would like, in part because there's a causality. People can interpret the data from the other way. Like that the removal happened because of the return to use. So I just want to acknowledge that there's more specific, better sort of more clear data would be probably helpful. But I mean, this is a huge topic. But I think that so what tends to happen, regardless of whether somebody's actually, in treatment, not in treatment, and all that sort of stuff. But, what tends to happen is there's a drug test, during the birthing hospitalization. It's a point of care, drug test. It's a presumptive test. It's an immunoassay. It's not a definitive, confirmatory test, either of the pregnant person or of the newborn. And any positive test result is the impetus for reporting. And that's why healthcare providers are the primary driver of, the epidemic of reporting. And the reason for the test, I think needs to be interrogated by hospitals. These are rarely like clinically indicated. In many ways, they might be a moral test or immoral test. They're a parenting test. They're sometimes done based upon like misinformation. Hospitals think they're, or providers think they're required, by statute to drug test, which is never the case, but rarely the case, and certainly not the case at the federal level. Like the federal CAPTA, which is the Child Abuse Prevention Treatment Act, says nothing about drug testing. And hospitals think it's their policies, but sometimes when you go down the rabbit hole, there actually isn't, a policy there. And many of these tests are being done not transparently. So there's not informed consent. And by that, I mean less like signing a document and more, explaining to the person what the indication for the test is, what happens with the information, how you're going to share it, and what are the consequences. And all the professional society guidance, ACOG, ASAM, AAP, even CDC, WHO, among others, like all state that, there should be informed consent for drug testing during the birthing hospitalization, and that informed consent also rests on another, piece of, human rights, which is the right of refusal. And that and that too is, not being well adopted. My sense now is that what would be better, I think that informed consent, written informed consent with clear transparency is the ideal, but I would settle for almost like a Miranda rights, that you explain, why you're doing what you're doing, the same way, that Miranda, rights are utilized at the, the moment of arrest. And explain what people's, rights are at, during the birthing hospitalization, and exactly what that would look like. I don't feel like I have good details on that yet. But I think that's a different, a potentially more acceptable strategy.
Thank you. We have time for maybe one more quick question if anybody has one. Dr. Terplan, if people have follow-up questions, can they connect you?
Yeah, please do. I think I put my email on the first slide, but it's not open in front of me, but it's there. If it's not there, that was an error, and it's there, so that, yes, please do reach out with questions and etc.
Wonderful, thank you. And for those of you, there was a poll asking if you would like a certificate for continuing education units. And so if you indicated yes, we will send that to you. And this webinar will also be posted on the CPO website, which is cpo.uoregon.edu. And thank you everybody for attending, and thank you especially Dr. Terplan for your time today. It's just, yeah, I think for me, I am just still digesting all of the things you presented, and I'm grateful for your time. And yeah, thank you all for attending, and I look forward to connecting with you again soon.
Yeah, well, thank you very much for inviting me, and I look forward to future conversations.
Absolutely, thanks. Bye.